Hi, I'm Damien Marucci and welcome to the video discussion of the April 4, 2012 Journal Club, which was held at St Vincent's Hospital in Sydney. As usual, we looked at 4 papers. The first paper was from the recent PRS by Mesic et al, and it's called The Importance of a Skin Bridge in Peripheral Tissue Perfusion in Perforated Flaps. So this paper looked at the perfusion of islanded and non-islanded perforated flaps using a DIEP model. We thought the model was very interesting. They then used fluorescent video angiography in order to assess blood flow within the flap. People had a lot of problems with the design of this flap though. We weren't certain whether this flap was actually measuring arterial supply to the flap or whether in fact the increased blood flow which was found was actually due to decreased venous drainage. By dividing the skin bridge, it was thought, are we in fact just impairing the venous outflow from the flap, and therefore the video angiography was picking up an increased signal, but not due to improved arterial circulation due to eliminating the Steele phenomenon, but rather just venous congestion within the flap. Many people at the Journal Club also pointed out that it takes more than 24 hours for circulation within a flap to become stable. So performing this particular study so quickly after the flap has been raised and or the skin bridge divided may not necessarily reflect the ongoing circulatory status within the flap. It was suggested a way of improving the study would have been to isolate the perforated vein and selectively clamping that vein and seeing what effect that had on the fluorescent video angiography. If that showed increased signal, then it would be clear that the results could be explained by impaired venous drainage rather than improved arterial supply. It was acknowledged that this is an important clinical question and it's something that is raised by surgeons who do perforated flaps and who are always claiming that the circulation is improved by dividing the skin bridge. This is an important clinical question, but I don't think that it's been answered just yet. The second paper we looked at was the Superior Thyroid Artery Perforated Flap Anatomical Study in Clinical Series by Wilson et al. From Melbourne, and this was also published in a recent PRS. This was a clinical, anatomical and radiological study, and it described the local regional fasciocutaneous flap for preauricular defects predominantly based on perforated vessels arising from the superior thyroid artery at the craniocaudal midpoint of the anterior margin of the sternocleidomastoid muscle. It was thought this was a very good description of the flap. It seemed to have a good colour and tissue match for preauricular defects and can also preclude the need for a free flap in many of these patients. Some of the questions raised were what the difference was between this flap and previously described platysma flaps, and also many of the people at the Journal Club had concerns about the location of the draining vein, although it was pointed out it was probably just the vena comitatus travelling with the perforated flap. Overall, we thought this was a good flap which was well described. The paper made a point that a CT angiogram was done with all cases, and the only case they had a problem with was with the one case where they hadn't done a CT angiogram, but we thought that probably you may not need to do a CT angiogram in all cases and that Doppler may be sufficient. The final 2 papers we did were concerning the dorsal metacarpal artery perforated flap. The first paper, which was the classic paper, was the distally based dorsal hand flap by Quaber et al. This was published in the British Journal of Plastic Surgery in 1990, and this classic paper described the workhorse reverse perforated flap for the reconstruction of dorsal hand and proximal phalangeal defects. The second paper was by Sebastian et al. From PRS in 2011, and it was entitled The Application of the Dorsal Metacarpal Artery Perforated Flap for Resurfacing Soft Tissue Defects Proximal to the Fingertips. This paper described the author's experience with this useful flap for both dorsal hand and proximal finger reconstruction, and it described variations in the technique to adapt the flap for different defect sites and size, in particular for how to get the flaps further distally for dorsal distal coverage and also even for volar coverage. Everyone agreed this is a great flap. Both of these papers were excellent papers. There was an excellent option for for including extensive tendon as a vascularized graft. Practically, if a good sized vein was seen during raising of the flap, flap venous drainage really should be fine. At the end of the case, even if the flap appears pale or white, it was thought just to sit tight, leave the flap in situ, and the vast majority of times the flap will be fine. The Dynasite was considered to be excellent. In an extended flap, consider using a vein graft in order to increase venous drainage. That concludes our discussion of the papers. If you are at the Journal Club, thank you for being there. If you couldn't be there, thanks for your attention now. Our next Journal Club will be in 4 weeks' time.